today is focusing on medical operations coordinating centers. I think many of you heard an awful lot about medical operations coordinating centers, or MOCCs, before, but I think across the New England region, across the country, people are in different stages of planning and readiness for MOCCs. And so incredibly excited to have really a leading national expert with us involved in the MOCC conversations, Dr. John Hick, as well as a leading local and national expert, Ms. Stephanie Locke, to talk to us about the New Hampshire experience. The state of New Hampshire has been doing really extraordinary work in turning this from theory into practice, and we're going to hear about the work in New Hampshire, which I'm so excited for her to be able to share with everybody. Next slide. We are extremely grateful to acknowledge that this work has been funded by the Administration for Strategic Preparedness and Response within the U.S. Department of Health and Human Services, ASPR within RDHRS, and both the Regional Disaster Health Response System and the Regional Emerging Special Pathogen Treatment Center, the RDHRS and the RESPTC programs, are very grateful to acknowledge that funding. Next slide. The content that is being presented here is only reflective of the individual speakers, and although these programs are funded by the United States government, obviously we do not speak for the government and is not meant to be medical advice, diagnosis, or treatment. The speakers have no affiliation or conflicts to disclose, but we'll offer another slide about that in just a second. Next slide. And so there are three of us that are speaking. I have introduced myself. Let me let you know about Dr. Hick. Dr. John Hick is a faculty emergency physician at Hennepin Healthcare and a professor of emergency medicine at the University of Minnesota Medical School. He serves as the deputy medical director for Hennepin County Emergency Medical Services, as well as the medical director for emergency preparedness at Hennepin Healthcare. Dr. Hick also serves as the assistant medical director for LifeLink 3 Aeromedical Services in Minnesota. We also are really excited to have Stephanie Locke with us. Stephanie is the Bureau Chief of Emergency Response and Recovery in the New Hampshire Division of Public Health Services, Department of Health and Human Services. She has been serving in this role for a while now, and under her leadership, the Bureau leads preparedness response activities for all ESF 6 and ESF 8 activities for New Hampshire. She coordinates the healthcare medical surge events response across the state and deploys across the state to support medical surges, healthcare evacuations, and public health testing clinics and points of dispensing. So really extraordinary partners to have here. We're so grateful for them. And we will dive in. Next slide. So what we're going to do before I hand it over to Dr. Hick is talk about how a MOCC can improve coordination and support across healthcare entities during an emergency response. There's really, again, so much that has been changing since the term MOCC was first coined only a few years ago. We'll talk about what it could be, what it can be, in a sense, what it must be, with talking about the core functions of what a MOCC, both at a state and a regional, meaning a multi-state level, can be. We'll talk about some real world scenarios, and again, give enormous credit to Stephanie, to the state of New Hampshire for the work that they have done so far, both thinking about this, but putting it into practice, as she will illustrate. And then we'll talk about other possibilities for how MOCCs can help support emergency medical coordination overall. Next slide. So with that, I'm going to turn it over to Dr. Hick. And again, please remember to put your questions in the Q&A as you go through, and we'll try and keep a good eye on them. Dr. Hick?
Paul, you calling me Dr. Hick sounds just wrong, but really grateful for the opportunity to be here today. As Paul mentioned, I don't have any specific interest to disclose. I'm not speaking on behalf of anyone specifically today besides myself. I do just want to acknowledge, even though it wasn't specifically required in the disclosure, that I did provide consultation to the state of New Hampshire in 24-25 as they began some of the MOCC activity planning that you'll hear more about later, which has been, I think, just a tremendous success. Next slide. So I just want to, some of you may be really familiar with MOCCs and some of you may not be very familiar with MOCCs. And I think one of the things I want to do is just kind of level set a little bit. So some of you will see some information you're very familiar with, but I think there's going to be a little bit of takeaways for everyone. But the main thing that I think really came out of COVID-19 was the fact that we really didn't use crisis standards of care in the way that it needed to be done as far as establishing equitable access to care and developing regional consistency of care. And so much of that is around regional coordination that healthcare coalitions and the RDHRS and others do, which is you got to either bring in resources, transfer patients, or triage the resources. And so movement of those resources, movement of those patients is really core to what we do. The Healthcare Coalition plays a crucial role. Medical Operations Coordination Centers, or MOCCs, play a very key role, I think, in patient transfer management and monitoring and balancing load across the system to provide that consistency. So in order to do that, they really are kind of the air traffic control a little bit, although, again, MOCCs always backstop, not replace existing referral patterns in an area. And a lot of times the MOCCs are a gateway to additional legal protections and regulatory support, during an event. So next slide. So this was just, I think, a really helpful map to kind of level set a little about what we were seeing in COVID-19. So the yellow dots are really overwhelmed hospitals, and anything blue or gray is not overwhelmed. And so you can see that even during this time when New York City was really peaking and surging, tremendous hospital loads, there were hospitals, within 50, 100 miles that, really had some capacity that could have been leveraged. And I think as we look at future events and how we might move staff and resources and patients, around even the country, whether it's a pandemic or a large-scale combat operation scenario, a wartime scenario, we're going to have to figure that out. And I think MOCCs are a big part of that solution for, monitoring capacity and then putting the patients in the right place at the right time. Next slide. So there's been a fair amount published on just the risk of excess deaths in hospitals that are overloaded. So Samir Kadri, Sentinel paper in Annals of Internal Medicine, and multiple others from our country as well as Scandinavia, from Europe, looking at how overloading in ICUs, resulted in increased mortality. So we've got pretty compelling data that excess loading of critical care is really problematic for patients. So I think we've got really good patient safety reasons to work on this pretty aggressively together. Next slide. And it's not going to get better. There was the Lecter article from JAMA, amongst others, that are basically just showing that, hospital beds are contracting, not expanding, and making the best use we can of the hospital beds we have. And that includes suburban, exurban, rural hospital beds. We're not going to be able to rely on the tertiary care centers for our bed capacity. Next slide. I just want to acknowledge that when we talk about planning for surge, we're talking about supplies, space, staff, and stuff, or if you want to talk about, supplies, space, systems, and staff. You can talk about supplies or stuff, doesn't matter. But those really develop capacity and resilience. And when we look at root cause analysis, and this is the suggested fishbone that CMS recommends for root cause analysis of a poor outcome, we're really looking at the same stuff. And so I really look at this as a fundamental patient safety issue. We're really trying to develop capacity, but at the same time, we're trying to maintain patient safety to the degree possible based on the resources available. Next slide. So a MOCC is a regional hub for capacity management. Again, it backstops, doesn't replace existing services. You guys, many of you have very robust patient transfer centers, figuring out how those work together, during an emergency where systems do become overloaded, where people don't have beds, then what? And the MOCC really is designed specifically for those type of scenarios. The monitoring is important, and so having some degree of data flow to understand where capacity sits right now, and it's been really instructive in the Seattle area. They can predict very, very well when their MOCC is going to get busy based on the capacity monitoring, and so then they can ramp up that staffing and ramp up those functions. So transfer management really is about 80% usually of MOCC functions, and load balancing is when we're moving patients from overwhelmed facilities to other facilities, or in some cases it may even be to other regions. But it's a single phone call. So if you're a rural hospital and you're spending hours on the phone trying to find a tertiary center to accept your patient, this is great news for you. The MOCC may also provide additional support We found during COVID that some MOCCs were actually helping manage supplies like PPE as well as staffing. Next slide. So a MOCC tries to get the patient to the right resource, and that could be a subspecialty resources like dialysis or ECMO, or it could be just a general critical care resource, but we're trying to really get that time to transfer down. And there's some initial data that shows that states that implemented MOCCs during COVID-19 saw that happen, that time to transfers were reduced when MOCCs were implemented. And again, that's coming out of Samir Kadri's cadre of great researchers at NIH. So a MOCC maintains equity of access, and I think that's so important because we saw too many times that especially patients in rural hospitals didn't get access to the care that they needed, and if they had walked into a tertiary care center and needed dialysis, they would have got that, but sometimes coming into a rural facility essentially meant that they would wind up dying there because they didn't have a ventilator, they didn't have dialysis, etc. I find that unacceptable. So making sure also that we can provide consultation for care in place, because there are patients that can be managed with the resources in the hospital where the patient currently is. And I think leveraging that on a daily basis, getting providers more comfortable with doing some critical or pediatric or other care in place is a huge advantage to the entire system and to the patients that can stay closer to home. At the end of the day, though, when we're out of beds and out of resources and we've got emergency transfers, part of what a MOCC does is to prioritize transfers during high volume periods when we can't meet all the requests, either because we don't have beds, we don't have transport resources, or we don't have both. Next slide. Optimally, a MOCC is operating 24/7. Most MOCC operations are virtual at this point, and so a lot of the monitoring really does take place fairly passively, and there's occasional one-off calls that are a little bit unusual circumstances, but really having trained medical staff that are able to engage pretty rapidly and make sure that we have that consultation, that prioritization available, or the recognition of an emergency condition that cannot wait and sit on a list waiting for transfer. That's a really important component of what MOCCs do. Ideally, that advice is legally protected. Now, if it's within a healthcare system, that's usually pretty well covered, but once we get outside of a system or across state lines, things start to get pretty murky. And so it's really important to make sure that the person that's providing the advice, the prioritization, that they know that either their employer's medical malpractice or statewide legal protections are going to cover that. Another thing that sometimes, back on that last slide, I'll just mention quickly that some areas do use MOCCs for long-term care placement, for behavioral health placement, and those can be really helpful to get buy-in from the hospital systems, because those are all challenges that we face on a daily basis, is moving patients into those residential beds. Next slide. So a few use cases I think that are important to consider is the daily use case, where we do have, occasional emergency transfer situations that need a specialized resource. Might be ERCP or ECMO or something that we just can't, get, and we need somebody to be the decision maker and have an algorithm in place that everybody has agreed to. Disaster situations, I think, pretty much speak for themselves. Stephanie will talk a little bit about their experience with an evacuation scenario that, fits nicely with what MOCCs can do. Disease-based scenarios like a pandemic, but also special pathogens. If we have a situation where we have to prioritize patients for transfer to a RESPTC center, one of the regional treatment centers, or make decisions, in pretty quick succession about a number of patients, that can be very helpful to have a MOCC engaged in that. And then a defense scenario, if we did enter into a large-scale combat operation, wartime scenario, when we're bringing lots of injured casualties back, having a MOCC available to monitor capacity and distribute patients, as well as communicate with Department of Defense, Department of War, about what regional capacity exists, and help them hopefully prioritize, where patients may go. But at the end of the day, the development of MOCCs depends on what I call the 3 Rs, which are relationships, regulation, and reimbursement. And if you haven't taken the time to build the relationships to drive this through cooperative agreements and drive this through mutual understanding of the need, then you're going to have to lean a lot harder on regulation and reimbursement, neither of which healthcare coalitions really control. But I do think that as time goes on, we'll see CMS and others take more of a patient safety interest, especially as ED boarding data becomes required for submission next year and electronically the following year. And reimbursement, who knows? We may wind up seeing some good reimbursement, case studies with being able to supply better reimbursement to hospitals for what we call lateral transfers or that load balancing, moving patients between hospitals. Some other carrots in there may be, on the horizon at some point. Next slide. I'll just draw your attention to the ASPR-Tracy mock toolkit version 3. A lot of great information in there, some sort of vocabulary information about what is a regional, a statewide, or an interstate mock, and also some good appendices for pediatric and burn use. Next slide. We did a mock summary through ASPR-Tracy also, and there was an additional effort that Eric Gorelnik and colleagues, and Paul was engaged in some of this as well, looked at a survey statewide of who operated MOCCs, particularly during COVID. What we found was that, about half of states had patient transfer centers. We didn't get responses from all those. Interestingly, only a couple of those could compel transfers, could kind of force emergency transfers, and only a few maintained ongoing operations, which I think is really unfortunate. A couple things out of ASPR-Tracy's summary of 10 of the MOCCs that we looked at, 7 directly engaged EMS, which I think is fantastic. And 7 out of the 10 were able to prioritize patients for transfer, which I think is a really great quality as well. Next slide. And our Minnesota example, we used the Critical Care Coordination Center, or C4, to coordinate requests, and we had over 5,000 requests across COVID for transfers during C4 operations, and about 1,800 ICU patients were placed. That would have been a better number, except that the state emergency declarations expired about halfway through the time the C4 was operational, and we lost some of our ability to prioritize and compel transfers and do the kind of things that made the operation really work when we did not have beds available in the system. But we were able to coordinate across the state of Minnesota into the eastern Dakotas and western Wisconsin, and to some degree northern Iowa. And I think it's instructive just to look at this heat map of where the transfers originated. You see some red dots at the very top of Minnesota. They're very close to the Canadian border. Some of these very small hospitals that were, resulting in a lot of critical care transfers that needed to be managed. And they were very, very grateful for this kind of support and some care in place advice. But just knowing they could make one phone call, and then we would take care of finding a place for the patient and not have them spend a lot of time on the phone. Next slide. There's definitely some, MOCCs in operation currently, which is great. Some of those use a pull function, and I know in the state of Massachusetts, Paul's done a great job in an incident-based pull function that you can put a patient's information in, and then basically another hospital can pull that patient, off of the list. So, Strachan, Texas, Georgia, Emory is working on with their RDHRS system. Oregon has a really nice state-based pull system. So there are definitely some systems in operation, but I think the unfortunate thing is, even though about half the states were operating these during COVID, the vast majority of them have gone away. Next slide. This is an example actually from Massachusetts of the pediatric bed board. During the triple-demic, we saw a number of jurisdictions, including Washington State, Massachusetts and Region 1 and others, make really good use of these, pull function bed boards. And then kind of the next step is that push function to be able to say, hey, we've got a high priority emergency patient that nobody's picking up, and we need to figure out where that patient's going to go. And having some agreements and algorithms in place and how to handle that, I think, is so important. Next slide. There is definitely opportunity, to systematize some of the way that we track bed availability. There's a nationwide burn capability board that is actually managed through the Nevada Hospital Association that tracks burn bed availability, but that's kind of separate from the vast majority of systems that are tracking capabilities on a state basis. And so integrating some of these informatics systems, I think, is just crucial for us to be able to provide more comprehensive services as we go forward. Next slide. Mental health, this is just a example of how we decreased days boarding in the emergency department in the Minneapolis-St. Paul area, utilizing a pull function bed board for mental health patients and having a once weekly coordination call to try to place those patients. This is just pediatric mental health, but really have achieved a nice reduction in boarding days in the emergency department, which benefits everybody. Next slide. So there's a lot of possible models for how MOCCs get built. And so the disaster models tend to be on more the public side. The daily models often run, through an existing patient transfer center or EMS dispatch or regional EMS coordination center. I think a lot of this is just kind of looking at who operates patient transfer centers and who are trusted brokers. There are a lot of areas where there is a dominant patient transfer center, but the other hospitals that aren't in that system don't really want them handling all the traffic. And so kind of working, through who are those trusted partners and how can we build, on what is being done on a day-to-day basis as far as patient movement and patient transfer, so that when things do tighten up and the system is under strain, that we have options and we work together to understand at what point are we going to say, yes, we will accept or we will take emergency patients, we will take, these type of patients. That brokering becomes really important. And I do think a lot of that can be done, voluntarily, but at the end of the day, we do need some often regulatory relief, we need funding, and to a degree, we need liability protections. Next slide. So just to distinguish, though, a MOCC is not a healthcare coalition. A MOCC is an operational entity that essentially manages patient transfers, and those basically are inter-hospital, they're between hospitals. So it doesn't take the place of an HCC. It is really an adjunctive operational entity. And so making sure that there is an entity that sets the policy, for the MOCC is going to be really important. And then very carefully working through any of those algorithm situations where you have an emergency condition that can't wait. How do those get handled in an equitable manner so that the patient does get the right care in a timely manner? And then agreeing on data requirements. There are some systems that get by with very little data. Arizona reacts, which is a service to rural unaffiliated hospitals that need to make urgent transfers. That is actually done with very little data. It's more of an algorithm about who's up next. And hey, if that works, then that works for the system. But as things get tighter and tighter and beds become less and less available, it is really helpful for the MOCC to have good data about loading. So what's the patient census in the ICUs compared to baseline, how many ventilators are in use, how many patients are on critical care interventions. So there's a host of data that I think makes a lot of sense for the MOCC to be able to monitor on an ongoing basis. And that really needs standardization at the state, regional, and honestly, federal level. Next slide. So in Minnesota, we did come up with a draft list of emergency conditions that we're working through with the Minnesota Hospital Association to try to come to some agreement about, we will never leave these conditions sit in a hospital that can't take care of them. And I think that's the first step in then saying, okay, now when that happens, what are we going to do about that? And so making sure that there are geographic as well as rotational algorithms that we can say, when this happens, here's what we propose to do. So those discussions are ongoing. We have another meeting coming up in September to try to define things a little bit better for what happens next and how long we will agree to let these conditions wait after we put out a notification to the hospitals in the area that could care for this condition. How long do we wait before we activate an algorithm that assigns that patient to a hospital? So next slide. Medical direction and consultation is so important to MOCC operations. Having someone that can work through those. Some of the emergency cases are easy, but others are not necessarily straightforward, and there's a high potential for deterioration. So making sure that somebody with critical care, hospitalist, emergency medicine background, can consult and provide some support, work through some issues, because issues always will come up. And then providing consultation. That's a really important function when we can't make that transfer quickly. It may not be an emergency condition, but it's something the hospital's not used to caring for, like a burn or a pediatric patient. Having those consultants available to be able to lean in and say, hey, we can help you through this. And, you can either do this on your own or you can do this on your own until we can, get you transport resources or get you an available bed. Next slide. Data is so important to this, as we talked about, but there's so much with data that we could spend literally an entire hour talking about that. But I think the main thing is what do you need to accomplish the mission? And then who gets to see all of the data? Who gets to see some of the data? Because one of the things that everybody hates about data during disasters is a lot of data gets provided to like the state and the feds, and then you have no idea what it gets used for and nobody ever sees it again. And I think one of the key distinctions here is that the data that is most useful at the local level for getting patients to the right hospital at the right time or monitoring capacity really isn't all that useful at the state or federal level. And this data that's useful at the state and federal level is useful to a degree at the local level, but it's much more about where are the patient loads and regionally who is being affected and where can we devote resources that'll probably make the most difference. So we've got some starts. There's NHSN data, there's the boarding data that CMS has now required be collected, but there's a lot missing here. And there's also a lot missing with the data agreements, again, about who can use these at local level, who can see them and when, because there's a lot of states that say, well, we want to see all the data all the time. And that's not a very comfortable place for the hospitals to be in, knowing the states are their regulators. And so we need to kind of figure out, like the aviation industry has, how do we have a trusted, portal or point of analysis, and then some throughput, so the right data gets into the right hands for the right purposes. Next slide. And this is just an example, during COVID of where the impact was nationally during one of the waves. And I think if you're looking at this as a Fed and you've got a certain number of disaster medical assistance teams or other assets at your disposal, this is the kind of data you want to be able to see and roll up. And so when requests are coming in from all of the states for resources, prioritizing those is hard because right now we really don't have good dashboards for what the patient loads actually look like in certain areas. And eventually it would be fantastic to be able to move, healthcare staff and other assets around the country, because not everyone is affected during a pandemic the same at once, and not everybody is going to be affected by natural disasters or wartime scenarios with casualties coming back to the United States for care. There's going to be a lot of disproportionate impact, and we need to figure out how to mitigate that. And the first part of that is just understanding what the impact is. Next slide. I mentioned the aviation model. The model has been developed for aviation as non-punitive. The data goes in, it gets vetted. There's quality analysis, but it balances the interests of all participants, and everyone trusts the process to result in better quality outcomes. And that unfortunately though is fairly costly, but that may be an avenue that we wind up taking with some of the healthcare data. Next slide. And then right sizing MOCCs, as AI and machine learning gets better, and if we're developing specific algorithms about how emergency referrals are handled, it may be very possible to make a lot of this automatic in a system. So there really is very little personnel needs. At the end of the day, though, there are always going to be problems that come up that need to be solved. And when that happens, the geography needs to be small enough that the people who are engaged in the conversation know the resources, know the geography, they know there's a mountain range, in between these two states. And so you can't just send an ambulance there, easily, or they know what the weather situation is. There's going to have to be enough local knowledge and enough local trust to be able to balance that. So, that's one of the issues with MOCCs is that on a daily basis, there's not a lot of personnel responsibilities, but when we really ramp up, it does become a pretty significant commitment for a number of people. Next slide. I'll just throw out that the federal coordinating centers, the 65 centers that coordinate casualties coming back from a overseas conflict, at least historically, that has been the plan. These are their locations. They don't necessarily match up with where our major metro areas are and where the need for coordination is. So, I'll just say, as we think about right-sizing MOCCs, you look at, there's a federal coordinating center in Boise, Idaho. There's one in Des Moines. Both of those areas only have a couple of major trauma centers. So do you need a MOCC when you've only got 2 phone calls to make? My thought would be probably not. But how many MOCCs do we really need, in the nation to make this work correctly? And I think we're still working through a lot of those things. Next slide. This is where the level 1 and 2 trauma centers are, by the way. And so again, there's some correlation, but not a lot. And as we look at the need for trauma care during wartime and other scenarios, making sure where there's a concentration of trauma centers and an ability to balance between different trauma centers, and how Boston did that with the Boston bombing, I think is an exemplary example of how multiple trauma centers in an area can care for, without getting into any kind of crisis situation, a pretty large number of casualties. Next slide. And we need to figure out return on investment. So I think properly executed, a MOCC could really improve boarding conditions in the emergency departments during times of strain. I think it could allow potentially elective procedures to continue if we managed loads across systems well. And that kind of ability to maintain rates of procedures and increase throughput is going to be really important, because if we can document good return on investment, we will have buy-in for these systems, there's no question. Next slide. So I think part of this is planning, and so there's an action collaborative going on through the National Academies of Medicine on MOCCs right now that Paul's actually a part of as well. And so we're trying to define, some additional taxonomy for MOCCs, and definitions around what is a MOCC and what is not. Trying to establish a research agenda on how do we show some of the value, and we've, taken some first steps have been taken there, which is fantastic. Looking at some of the legal and regulatory options for operating MOCCs without, concern for legal liability for the consultants. And then really starting to look at catchment area analysis and patient referral patterns. And a lot of those don't follow state lines. So MOCCs are going to need to be established, in jurisdictions, but they're going to have to serve multiple jurisdictions. But again, what does that right sizing look like across different patient catchment areas? And really try to get to some cost effectiveness analysis about, what do MOCCs cost, and what do they wind up saving the healthcare systems, and what do they wind up saving potentially in outcomes, although that's going to be difficult data to get at. I think we need to keep pursuing that. And advocacy, there's no question that we've got a lot of momentum right now between American College of Surgeons and Department of War and ASPR and a whole lot of other folks behind MOCCs. But we need to be kind of asking for the same thing and making sure that there is sustainability, that we're not relying on, funding that could end, next year or the year after that, spool up MOCCs in a lot of areas and then have them come crashing to the ground. So next slide. So I hope that was a helpful overview and intro of some concepts and kind of where things are headed, and some challenges to setting up a successful medical operations coordination center. And now Stephanie is going to talk about how they did exactly that in New Hampshire. So Stephanie, I guess I'll just hand it over to you, and so good to be working with you again.
Nice to see you too, Dr. Hick. Thank you. So New Hampshire took a holistic approach to medical surge planning, and MOCC was a component of that. But we really tried to take a step back and say, how do we want to work with and respond to medical surge emergencies here in New Hampshire? And so you'll hear some of these concepts woven into both our planning and our responses that I'll share, and then including our next steps and how we want to continue this approach. But Dr. Hick did such a great job talking about MOCC that I will quickly move through this and just say we spent about a year getting buy-in for this concept. We looked at the after action reports from COVID and other responses. We saw glimpses of what a MOCC could and should be here in New Hampshire during the COVID-19 response in terms of load balancing and information sharing across the sectors. We saw clinical expertise come into play during the 2022 winter respiratory surge, where hospitals were having to keep pediatric patients that they would normally transfer out, but instead were able to manage them within their home hospital with clinical support from another facility. And then we had lots of conversations at Mercy exercises about a MOCC and what that could look like in New Hampshire. And that's where we had our aha moment, where we were tap dancing around the idea of the need for a MOCC and how we'd move patients during our fictional exercise. And it seemed to just click at that Mercy exercise, and the HEMCs, the Hospital Emergency Management Coordinators, became a huge champion of the MOCC concept and really had internal conversations with their hospitals. So throughout that year, of research and relationship engagement, I would say we worked with Dr. Hick, who helped us in developing our concept and reviewing some of our proposals. We worked with chief medical officers, chief nursing officers. We worked with the RDHRS and several others to be able to pull everyone together. And we put together a one-year plan for the development of a MOCC. So in June 2024, we pulled our multidisciplinary committee together. We did a brief presentation with Dr. Hick's work relative to the ASPR Tracy tool guide. And we talked about what was needed in New Hampshire. And we left with the idea that the MOCC in New Hampshire needed to be able to do load balancing, allocate resources, not come up with the crisis standards of care recommendations, but be able to implement the policies that the State Disaster Medical Advisory Committee had written and the commissioner and governor had approved. The MOCC needed to be able to do information sharing and create access to clinical expertise. And so we spent a month on each of these ideas, running them to ground and figuring out ways we could implement them. And in December 2024, we had a very large in-person workshop that Dr. Hick and Dr. Binger came up for, presented on the topics nationally of what was going on in MOCC, and again, regionally within Region 1, what resources were available. And we had a great discussion and decided we had 6 months to put together a plan to update it, adopt it, and then move forward. And so if you go to the next slide, you'll see that we walked into that MOCC seminar in June, recognizing what a MOCC tries to do based on the national toolkit. And where we ended at that seminar was the 4 pillars. And so it was adopted that the MOCC would focus on load balancing, information sharing, resource allocation, and clinical expertise. And when we left that workshop in December, the group added the underlying themes, which you'll see at the bottom right part of the screen, is legal considerations needed to be included throughout all the pillars, and stakeholder engagement needed to be included. And I think that goes back to the 3 R's that Dr. Hick was talking about. And New Hampshire's model really tried to incorporate that perspective into our MOCC. So on the next slide, you'll see that we have our concept of operations, which was adopted in June of 2025. And very quickly, we identified things that are going to be out of scope. So the MOCC is not meant to interfere with daily operations. It's not meant to coordinate pre-hospital EMS coordination. So 911 system is the 911 system, and we're not going to interfere with that. We took forced transfers off the table pretty early on in order to be able to continue to have the healthcare system engagement. And it became a patient safety concern that we would force a transfer into a hospital that perhaps didn't have the capacity or capability to manage it. And then any hospital that is part of a health system has exclusive rights to that healthcare system. And so we would not transfer into that health system, and instead the hospitals would coordinate their own internal transfers within those health systems. Some pretty big planning assumptions that needed to be agreed to early on was that if the MOCC is activated, all the hospitals need to participate. And so that way we're not competing for the same resources and same beds. And then we also acknowledge that the MOCC could be operational and has been operational even if the state EOC is not, which became a big resource and support for the healthcare system. So on the next slide, we have several activation levels, starting with enhanced monitoring. This happens a couple times a week if a CAT scan's down, if a hospital is on diversion. We're just following it to see what resources are needed and sharing information, and it culminates in a full-scale activation, which is full load balancing, information sharing, and creating access to clinical experts. This may or may not involve our federal partners, but it definitely involves the Region 1 RDHRS and our friends at ASPR Region 1. And on the next slide, we created an org chart that we thought would work, and I'll say we've changed it since this was conceptualized based on real-world responses, but this was where we thought we'd start. It's modeled after a pretty basic ICS structure, which the hospitals and those of us at the department are familiar using, but we'll talk about why we ended up changing that. But on the next slide, I just want to highlight some of the successes. We would not have been able to pull together this MOCC plan without all the hospitals participating, and they have all been participating. So from private nonprofit to specialized hospital, rehab hospitals, acute care hospitals, they've all been involved, which is great. And one of the big successes has really been premised on the idea of using current infrastructures, because this isn't a separately funded project that has its own dedicated funding or ability to grow something separately. We had to leverage resources that are currently available and then then just help organize ourselves around that. So we use our New Hampshire Fire Mobilization Plan to coordinate EMS assets across the state of New Hampshire. We work with hospital transfer centers that do this work every single day. And so if we needed to transfer into a health system, we would call that transfer center and they would coordinate among their affiliated organizations. And then we work with key partners such as RDHRS to advance the concept. We continue to meet monthly and work on these concepts and are using our MOCC exercises to be able to test and validate some of these concepts and then tweak from there. And so on the next slide, we did get the opportunity to use our MOCC. The ironic part is we had focused initially on the plan just on hospitals, and we're going to expand from there. And our first test case was with an assisted living facility. And so there's about a 65-bed assisted living facility called Wheelock Terrace in a more rural part of New Hampshire, but close to Dartmouth, our level 1 transport center. And so they had a boiler problem which required evacuation. We were notified several hours into this when the decision was made to evacuate. The fire marshal, the state fire marshal's office was ordering the evacuation and in concurrence with the local fire department. It was a time-sensitive evacuation. We needed to get them out in short order, but it was not immediate like a Joplin, Missouri situation. So we had some time to work with this. So for some response activities, you'll see the MOCC peppered throughout this, although it may not be as clear cut as what looks like on the MOCC plan, but I'll certainly try to tie all this together for you. So when we received our notification that there was going to be an activation, we immediately used our internal activation processes. So our federal partners knew about it, Homeland Security, Emergency Management knew about it, which allowed us to bring in all our state partners that needed to be involved. And the local first responders were involved, as well as we informed the healthcare systems in case we needed to transport to any of those facilities. We worked with our Granite State Healthcare Coalition. We're a single state coalition. And we were able to have an internal coordination call while everybody between my team and the Healthcare Coalition knew what their assignments were filling out the ICS chart, and we knew what our roles were. We deployed a liaison to the scene, which is part of our MOCC plan, and he was on scene within 10 minutes. It worked out very well. We deploy our liaisons based on where they are geographically in the state, and so this one arrived on scene within 10 minutes. And within 30 minutes of that first activation, we had our large-scale coordination call, which is mentioned in our MOCC plan. So we had the facility leadership team who knew their emergency operation plan, but had never had to implement it. We had the state fire marshal's office, the local first responders, the healthcare coalition, Homeland Security, and emergency management. And the next one became really pivotal, which is DHHS licensing, which ties back to that regulatory piece in order to be able to get waivers in place. I'll say both the department's commissioner and the governor were made aware through the appropriate state agencies. And so that way, if executive orders were needed, we could have requested them because they were brought into the conversation early on. So on the next slide, you'll see that we had our first coordination call. It lasted about 30 minutes, which feels like forever in an emergency, but we had a lot to work through. So we did a resident and staff accountability, making sure everyone was accounted for. We determined that there were only 62 residents that needed placement and made sure there was a communications plan in place with the families. We worked on load balancing by identifying potential receiving facilities. We used our alternate health system plan and identified a hotel where residents could be safely placed, and we got the waivers issued in the fire marshal's office to bless that plan and be able to place people there and take care of them clinically. And then we allocated transportation resources from a variety of partners. And so at the end of the 30 minutes, we had identified response strategies that state and local partners agreed to. All the necessary waivers were in place to move forward, and all of the agencies knew their roles and responsibilities and had their assignments on what they were going to work on for the next hour. And we had set up a cadence of ongoing coordination calls. So again, it's a different scenario, but all 4 pillars of the MOCC are represented in what was completed in that first coordination call. And so on the next slide, you'll see at the end of the day, all 62 residents were placed, and they were placed within 3 hours of us being activated. We had several that were placed at a hotel, but about half of them went home, which again aligns with hospitals doing a rapid discharge at the beginning of an emergency as well. And so that concept was kind of validated and shown through here. We worked on resource allocation in terms of staffing. Everybody within the ESF8 structure and the incident management team had an assignment. The facility staff were assigned to the temporary receiving facilities to provide coverage 24/7. We had used local resources for transportation. And then we worked on information sharing over the next couple of days in terms of writing a repatriation plan for the facility and with their involvement. And then we worked on some intermediate resources, behavioral health resources to help the residents and the staff following this event. And so we went back on Saturday, November 1st. We deployed an entire incident management team to Wheelock Terrace, thinking that they were coming back. We trained the staff on the repatriation plan, the accountability system, issuing the wristbands for accountability, and we deployed volunteers to our location to be able to help us. So we used our MRC volunteers and our regional public health networks to help augment our staff. And about an hour after arrival, we realized it was all for naught. The boiler failed again, and so we were going to have to activate the MOCC. And so we actually did the MOCC right on scene. We just pivoted. Instead of being a repatriation team, we were now the MOCC team, and we're able to reload balance people who could no longer stay at home and needed to be placed, as well as move people across facilities. We opened up a call center for them to be able to share information, and we checked in with the host agencies to make sure they had the information that they needed. And so our lessons learned from this really quickly was that the community support was amazing. Dartmouth College loaned us resources, beds, et cetera. New Hampshire Hospital, our state psychiatric hospital, was great. And the volunteers were amazing. So at the end of that day, all 62 residents were accounted for and placed in appropriate facilities where they could stay until all repairs were complete. And so in the next slide, I'll just say that some of the huge strengths that we had were the on-site liaison role was validated, which was great. That was a MOCC concept. The Wheelock Terrace staff were great at knowing their residents and helping to prioritize the order of evacuation, which is, again, something that is a planning assumption for hospitals in the MOCC. And so that concept was tested. And the good news is that the residents returned home safe and sound about a week later. And Wheelock Terrace did it independent of us. And anytime we can leave a facility stronger than we found them, I think is a huge win for any system. And so we appreciate their partnership. We learned a lot in terms of residential care facilities may have space, but they don't have beds or staff. And so we need to have our own bed cache to be able to do that and really invest in a statewide surge staffing plan to be able to use volunteers in other healthcare settings. It worked here, but we want to talk about it and look at using it in the hospital setting as well. And so on the next slide, we focused our MRC on how to use some of these MOCC concepts that we had refined. So if you go to the next slide, the scenario is we had 2 Seacoast hospitals that were evacuating due to a weather event. After they had done their rapid discharges and had moved patients within their own health system, they called the MOCC and we had 244 patients to move. And so on the next slide, we learned a lot. It was a great MRC. It was about 3 hours long. We discovered we had resources available to the system through the VA that we didn't even know existed, so we could move staff and transportation assets and beds, et cetera. Home health was willing to convert conference rooms for space and do congregate setting, and so we issued waivers for that as well. Hospitals really stretched and accepted more patients than they would normally take outside of the disaster setting, and that connection with the hospital transfer centers worked very, very well in this situation as well. And of course, we have things that we learned, which are highlighted on the next slide. And involve, we need a scalable approach to matching beds. We had the luxury of having patients pre-identified and uploaded into our system, but that wouldn't be available during a disaster. And so how that works needs to be explored. We really need a patient tracking software, which we are trying to procure. And then we need service lines and bed typing, which we've actually got some work going on with that, which is great. So overall, it was a great exercise. We learned a lot. We need to focus more on EMS moving forward and then building depth in staffing to be able to fill the various positions. And so on the next slide, in case you're curious how the MRC ended, we were able to match 203 patients across home health, residential care, and hospitals within New Hampshire. Our state psychiatric facility expanded and took more than they would normally take, which left us with 41 patients that weren't matched. And according to our plan, those 41 41 would be the one we turn to RDHRS and ask them to help us find placement for. And so that was the end of the exercise and outside the scope, but that was our plan at the conclusion of our exercise, was to pull RDHRS in to help with the matching. And so very quickly, if we go on to next steps, we have a lot of work to do. We've learned a lot. We've updated our org chart. You can see we've added positions, notably the triage officer, who will take that census line list and do a quick review of who the medically or socially complex patients may be, so we can have a separate team start working on those. We've expanded the EMS section, and we've really filled out the various sections, recognizing that the on-site liaison role is now a team of people we will deploy to help with that on-scene management. And so we have our patient movement plan, which we're in the process of adopting this June. We've adopted the RDHRS bed definitions. We're working on creating some New Hampshire specific bed definitions where they didn't exist elsewhere, focusing on ICU for adults and pediatrics and rehab beds. They've been a big partner in picking up discharges for us, and then adopting service line definitions so that receiving facilities are able to help determine where that patient would best fit within their own facility. And so if we go back to the beginning, which is holistically looking at it, these are the plans that we're working on in terms of updating, making sure that MOCC, crisis standards of care, and that state disaster medical advisory committee are infused throughout all our plans. We're going to do our patient movement plan exercise in this next budget period, which will culminate in a full-scale exercise in BP5. And then we have our annual Mercy that we'll do in the spring, which will focus pretty heavily on EMS. So we've learned a lot. We have a lot more to learn. I would love to connect with others and hear how you're doing things in your states, but happy to share what we've learned in the meantime. So I think I'll turn it back to you, Dr. Bidinger.
Oh, that's great. Thank you so much, Stephanie. That was just amazing content. We are going to be very close to time. I'm going to try and sneak in a question for each of you if I can. And John, I'll start with you first. You know, lots of folks are looking at MOCCs. Not as many have made the extraordinary progress that New Hampshire and Stephanie have made. But for folks who are trying to get started, what would you give as your best advice if they just, you know, this can seem overwhelming, it's complex, there's so much to consider. What do you think you would say to people who are just trying to figure out a way to get started, to get the ball rolling?
Yeah, I think the first is just, curiosity about how the transfer management occurs in the area and where the roadblocks are. I think a lot of places are seeing issues with rural hospitals getting patients into tertiary centers in a timely manner during seasonal influenza, outbreaks and other seasonal strain conditions. So I think kind of starting with those problems and then thinking about, within or outside of existing healthcare systems, how are those managed? What are the existing patient transfer centers that handle those? Does EMS have any regional capabilities there? Are there any regional, otherwise resource centers for EMS or other health entities that could be leveraged? And just kind of think about, who has resources that could help solve some of the issues in the area and build on that. I think as you figure out what the problems are and potential solutions, that will naturally lead to, well, it would be good to have, bed availability data. It would be good to each have, a clear understanding of what we mean when we talk about an ICU bed, because those definitions differ a lot between, different hospitals. So I think the conversations naturally lead to the right places when everyone comes in with a problem-solving, posture and curiosity and a willingness to kind of work through, some of the issues and find solutions. So when that's the basis, I think that is the optimal basis for a MOCC, because that is the relationship development that relies on everybody understanding a common need and being there for a common reason.
Fantastic. Thank you. That's a very, very helpful advice. And Stephanie, you touched on this already, but I think it's just so important to dive into. You and the state took your time, as you said, at the beginning to get buy-in, to really listen to the stakeholders. And, from my perspective, that just seems to have been such an integral part of the success of your effort. And I wondered if you wanted to say any more about what you think was so productive in that process to get everybody on board so that they've stayed on board all the way through the work that you're doing.
I think a lot of it came down to we had a lot of listening sessions with the different stakeholders to understand what their needs and concerns were. We spent a lot of time researching the lessons learned from the COVID response and other responses. And then we brought in Dr. Hick, who's that national SME on MOCCs, to say, here is a potential solution, what, and then take it and tweak it for what will work in New Hampshire. And so having that voice of authority come in and say, here's a solution, take it and work, and then having the state say, what do you want? And then working all of us together to be able to create a solution that worked for New Hampshire, got that initial buy-in, and then it's just continually to check in with our partners to make sure what we're doing continues to make sense. And then we've also presented that Wheelock Terrace presentation to some of our partners, just to show how their work has come to fruition and to be able to tweak things from there. So it's just that constant relationship management and getting feedback along the way.
Yes,
no, that's
success breeds
please.
success. Oh, sorry, success breeds success. So I think, credit to Stephanie and company, but they had a big tent. They invited, all the partners and had really good dialogue and honest dialogue. There are some healthcare systems in their area that were willing to take on a bigger role, but realized that there probably just was not the trust there in their system to act as the manager. And so, they said, okay, let's figure out a different option. And so people came in with their only agenda being, let's try to solve the problem rather than I have a health system agenda that I want to make sure, gets satisfied. And when that happens, really great work gets done.
Yeah, no, well said. Well, I can't thank both of you enough. This was really a fantastic hour. I hope everybody who has been attending really enjoys it. I will point out again, a recording of this webinar will be archived and available on the RDHRS.org website in about a day or so. So please, if you think others might want to listen to this and learn from what was just shared, let them know to go find this webinar there. Thank you, Dr. Hick. Thank you, Ms. Locke. So excited to have you both join us. We'll see everyone again for our next webinar.
A pleasure, Paul. Thanks, everybody, for all you do.